Can you define tremor? Anish, can you start?
Yes, sir. Tremor is a rhythmic, oscillatory, involuntary rhythmic and oscillatory movement of any part of the body.
Yeah, that's good. There are 3 points there. What are the 3 points in the definition?
It's involuntary,
Involuntary,
rhythmic, and oscillatory.
Oscillate. That's how you learn that, you know, the points, the main. What you said had all the 3 points. So, so that is what is tremor, okay? And do you know any classification of tremor, Prasanna?
Fine, coarse.
Yeah, depends on the amplitude, frequency in hertz, you know, 4 to 12 hertz is the hertz, you know, H-E-R-T-Z, the unit. So there are different classifications. Of course, you can say genetic, acquired, idiopathic, that is one general classification. Genetic, acquired, idiopathic. Of course, that doesn't help very much in the, but a broad classification. And what are the, any other classification, you know? Fine, coarse, that is one. An example of a fine tremor, Prasanna, you have to unmute your mic. Yeah.
Hyperthyroidism.
Yes, thyroid. You must say hyperthyroidism. Hyperthyroidism. Okay. Answering always in a complete. Okay. What is the coarse tremor? Can you give an example, Anish?
Parkinson's.
Yes, Parkinsonism is not very fine. It's a coarse tremor. Cerebellar tremor is a coarse tremor. Okay, so that is fine. And one more example of fine tremor.
Wilson's.
Fine tremor. No. Wilson's is actually a Parkinsonism type, like, and also a wing beating tremor in Wilson's disease. Wing beating tremor. It's a coarse tremor, actually. While we have mentioned the Wilson's, you know, you ask the patient to abduct the arms and flex the knee, elbow, and the hand stretched, and you will find tremor like this, you know, wing beating tremor. That is, by the way, you know, because you have mentioned it, thought we can finish that. Okay. Any other classification, you know?
Resting and action.
Pardon?
Resting tremors and action tremors.
Yes, yes, yes. So resting and action, that's a useful classification. Can you tell what is the yeah, I think, yes. Do we have anybody else in the our new students? Anybody is here?
Yeah, Aravind is here.
Aravind. Okay. Aravind, him. Aravind is around? Okay. Okay. Aravind is there. Okay, okay. Okay. Can you, of course, Aravind, if you can mute, yeah. Resting tremor, can you define? Aravind, can you can unmute your mic. Aravind's mic is mute.
I'm in Watts, so it's very loud in here. Resting tremor,
Okay.
when patient
Okay, that's fine. Resting
when the
tremor,
patient
can
is
you?
not when the
Yes.
patient isn't doing any kind of action, but still the tremors are present.
Okay, okay, that is fine. Can you improve upon it, Anish? Resting tremor. Not doing any action. That is one. Okay.
Terminated by action.
Terminated by action. No, the resting tremor, the name itself. The limb affected is fully rested and supported and not having any action. Got 3 points there. Okay. What are the? It is fully resting and supported. So it should not be hand lifted up. Fully resting on a support. Fully resting, supported, and relaxed without doing any action. That is actually, so when you test it, you have to be sure that the patient is fully relaxed and not supporting, not doing any action. That is the important thing. Okay. Can you classify the action tremor, Prasanna?
Cerebellar.
Okay. That is the different, that's etiological classification. Okay. That cerebellar comes within that. I'll give you the what I was looking at the up-to-date, what is their up-to-date classification. I'll give you that. You can note it down and then further read about it. Okay. So one is a kinetic tremor. Other is postural tremor. Third is isometric. That is the first time I am also seeing that classification. But that is so under action tremor, 3 types. Can you repeat? I want to sure. Yes, Sai.
Yes.
Aravind is there. Aravind is there. Okay. I see Sai Prasanna Kumar. Is he also there?
Yes, sir. Yes. Yes, sir.
Oh.
Can you hear me, sir?
Yes, yes, I can. So can you repeat what I said, the classification of kinetic tremor? Action tremor, action tremor classified into 3.
Into kinetic, postural, and isometric tremors.
Yeah, is that clear? Okay, what is
Yes,
kinetic? The word kinetic itself means
movement.
When you do any action, that is why it comes under the action tremor. Kinetic means the tremor is roughly the same throughout the action, course of the action. Okay. So kinetic tremor, the simple kinetic tremor, intention tremor, task specific tremor. That's how up-to-date classifies into. I will say it again. In the kinetic tremor, there are 3. Simple kinetic tremor, intention tremor, task specific tremor. I'll explain that. Simple kinetic tremor means when you are asking the patient to do something, the tremor is static, the same throughout the range of action. Whereas intention tremor, the second type of kinetic tremor, the tremor increases in amplitude and the rhythm when the target is reached or nearing. Intention tremor of cerebellar disease. Okay? The crescendo of the tremor increases when the target is approached. Is that clear? I'll
Yes.
say it again. Under the kinetic, so the classification is resting tremor and action tremor. Under the action tremor, 3, kinetic tremor, postural tremor, isometric tremor. Under kinetic tremor, there are 3. Can you say what you have written, Prasanna? Under
Yes,
kinetic.
sir.
Uh,
Simple kinetic.
Yeah,
Yeah.
I will ask different people so you can. I was asking Prasanna, can you read what you have written? Under
crescendo
kinetic, under kinetic tremor, there are 3 types. Have you
simple,
written? Yeah.
simple, intention,
Yeah.
and task specific.
Yeah. Yeah. Task specific means, example is a writing tremor. Some people have tremor when they write only, when they sign the check book, bank book, etc. Or I have a patient who is a teacher. His problem is when he writes on the board, the hand. Otherwise, he doesn't have much problem in eating and other things. So we will say the classification again. One classification is on the genetic acquired idiopathic. Other is on the nature of the tremor in terms of the frequency and amplitude. We said fine goals. But more useful will be resting tremor, action tremor. Resting tremor is classical, Anish, that is Parkinsonism. Okay? Especially Parkinson's disease. Parkinson's plus tremor may be less or absent, and so PD means Parkinson's disease. Okay. Now, did you get intention tremor? You know, cerebellar. Task oriented or specific tremor, kinetic tremor is the writing tremor. What is postural tremor? Have you in the action tremor, kinetic tremor, postural tremor, isometric? What is action in the postural tremor? Have you seen any patient with a postural tremor? Anish?
Essential tremor.
Postural tremor. That is only on a posture. I have a patient, one of my relatives, who is an older lady. When she stands up, the tremor, what usually happens is the tremor is in the lower limb and the trunk, not so much in the hand. A posture, standing, then the tremor comes. And one of the drugs which is used are clonazepam in that condition, postural tremor. What is postural tremor? When the patient assumes a posture like standing, the pressure, the tremor increases, is mainly in the legs and the trunk. That is also called orthostatic tremor. Well, people who stand and get the tremor is called orthostatic. That's one of the postural tremors. What is isometric tremor? Is suppose you squeeze your hand, then the tremor comes, isometric tremor. that is also part of the kinetic tremor. I'll say it again, see whether you have noted it correct. The kinetic tremors are simple kinetic tremor, intention tremor, task-specific tremor, like writing. The second type of action tremor is postural tremor. Example, orthostatic tremor. And third is isometric tremor, where you do make a fist or squeezing an object, the tremor comes. What is a clinical way of bringing out a tremor? That is, so a patient says, I get the tremor. Sometimes when you are examining, the tremor. 1 minute, I'll just cancel this call. Another call was coming. When you want to bring out the tremor, do you know any maneuver? Patient just come, it says, I get tremor on the left upper limb. But when you examine, sometimes the tremor is not there. Do you know any method where you can bring out the tremor while in the OP or in the ward? One prisoner, do you know any method?
Ask the patient to stretch out the arms and fingers. Straighten out.
Little
Extend
louder, speaker. You can.
We have to ask the patient to extend the
louder,
arm.
more.
We have to ask the patient to extend the arm and abduct all the fingers.
I'll just 1 minute. One call was come. I'll just come back. Can you hear me? Okay, I think one call came and so I will just adjust that. Okay, now you can, what you do is that, suppose the patient came with a tremor, history of tremor on the left side. You ask the patient to move the right limb a few times like this, flexion, extension, okay, repeated movement. And then you do the opposite side, make the opposite side, make a repeated movement. Sometimes the affected side, the tremor will come. Then ask patient to walk. Sometimes the tremor is unwalked, second thing. Third is, give a mental task like
Hello, sir.
Hello,
Yes,
sir.
I think there was a connection problem. No.
Okay.
Can you hear me now?
Yes, sir.
Okay. Okay. What we'll do is that I can't. Okay. I'll just be back. There was a problem in the connection here, but you can hear me now?
Yes, sir.
Okay,
Yes,
okay,
yes, sir. Yes, sir.
okay. Yes, I think today there is some connection problem. So we were looking at the various uh, ways of looking at tremor. Okay, so today we will. Another way of classifying the tremor is depending on the anatomical distribution of the tremor. Okay, I'll give you the classification. You can focal, segmental, hemi-tremor, generalized tremor. Okay, that's easy to focal, segmental, hemi-tremor, and generalized. Clear? So when you examine a patient, you'll have to see where is it in one particular area only. Can you tell me one tremor which is focal you have seen in the during the last 2 years? Yes, sir. Prasanna, you can unmute and you can unmute your mic and any focal. Parkinsonism
Early
need not
stage.
be early stage, it can be focal. Yes, it can be only. One common thing you will see in the practice is titubation. You know titubation? What is titubation?
Head nodding.
Head nodding.
Rhythmic head nodding.
Yeah, yeah. Which condition do you get titubation commonly? For example, in Parkinsonism, do you get titubation commonly? Or which other type of tremor you get titubation? Or voice tremor? So have you seen any patient with voice tremor? The sound is tremulous, you know. You will see such patients. So that is called focal tremor. That is in essential tremor. Have you heard of the ET, capital ET, essential? One other previous terminology was benign essential tremor. You would have seen many people with a differential diagnosis of Parkinsonism. Okay, so essential tremor can be a voice tremor or a head tremor. That is something. So when you examine a patient, you have to see where is it anatomically. Is it in a particular area? The usefulness of that is in terms of the diagnosis. Have you heard about dystonic tremor? Sai, have you heard about dystonic tremor? Usually we don't talk much about that.
No, sir. No.
Have you, any of you seen the dystonic tremor is usually confined to the neck. So when a tremor is confined to neck, look for dystonia also, okay? The posturing, dystonia, main thing is the posturing. Head may be tilted to one side and remain for a while before it returns. And there is tremor associated. So focal tremor, segmental is one or two contiguous part of the body will be is affected, and one side is hemitremor, and okay. The other is isolated tremor and combined tremor, that is tremor plus. That is when tremor is there, what you have to see is there anything else associated with that? For example, Parkinson's disease, PD. Anish, what are the things you will look for?
Rigidity in Parkinson's.
Parkinson's, yes.
Yeah.
Can you
Rigidity.
tell us points? What
bradykinesia, rigidity, resting tremors, postural instability.
Yeah, okay. So when you have a tremor, you look for three other things. What are the three other things? That is when the tremor is combined with other things. That is what. Is it only tremor or is there something else? Three things to look for. Can you repeat it, Sai? What? Three things.
Yes, sir. One is rigidity, bradykinesia, and postural instability.
Postural instability. Okay. That is how you look at trying to understand what the tremor is. We have patients coming with tremor to the OP. Prasanna, you would have seen, what is one of the common causes of tremor you have seen in the OP, in the IP?
Essential tremors, Parkinsonism, cerebellar tremors.
Drug induced.
Okay. Pardon?
Salbutamol. Drug induced, salbutamol induced.
I think that's very important. Actually, when you have a patient coming with tremor, one of the first things to see is any drug causing the tremor. Okay. Can you tell me the drugs I was telling? Can you tell me some drugs which cause tremor? So immediately look at the drug list. That's important before we diagnose any other problem. Can you tell me a few drugs? Each of you
beta
can.
agonist, sir.
Yeah. Tell the specific drug.
Salbutamol, formoterol.
Yes. All that group, salbutamol, terbutaline, all those drugs. The common drugs which are. Any other drugs have you found? Which are they are not very common. Which one? Which drug? You must tell the specific drug. Anish, have you seen any patient with
Atropine.
Drug?
I see.
Atropine, which we don't use atropine very much. Antidepressants. You will see that in many patients who come with antidepressants, it may have tremor. Some toxins like mercury I have had. What is the situation called mercury tremor, mercurial tremor? Have you seen any patient here? I have seen so many patients here. Some of them I had sent earlier years, sent to Vellore to study certain Siddha medicines they were taking. That's one of the cause I have got. Velli basmam. Velli means, what does it mean? It is like silvery color. Then we got CMC. I sent them because they came with tremor and peripheral neuro, marked tremulousness. They analyzed and found the powder contained, if it's white powder, mostly mercury. If it is a brown color, mercury plus lead. I was telling the story mainly because when you have a patient with tremor and fasciculation and peripheral neuropathy, insomnia, ask for Siddha medicine intake. That is one of the toxic causes of tremor. Okay, and Siddha medicine, they use heavy metals. Especially, I was telling you, we studied it. I sent them for nerve conduction and sent a sample of this powder, and that was many years ago, earlier. And I was telling that you will remember that when you have a patient unexplained, always ask for a medicine, or the Siddha medication. The Ayurvedic other medications use less of heavy metals. Okay. Now, have you heard the term tremor dominant Parkinson's disease? That is it. The name itself tells that in many patients with Parkinsonism, only tremor is there. Other things are minimal or absent, especially initially. So when you have a patient with tremor coming, even if there is no bradykinesia, etc., keep in mind Parkinsonism as a possibility. How will you differentiate Parkinson tremor from benign essential tremor or ET? Anish?
Parkinsonism tremors are asymmetrical.
Yeah.
Benign essential are symmetrical in nature.
Yes, usually symmetrical. You can say ordinarily symmetrical. That is one. Any other differences?
Then-
Each of you can think of some. Yeah.
Benign essential will respond to it is relieved with beta blockers.
Okay. Any other? We don't advise very much, but any other thing intake will reduce the benign essential. Alcohol. Okay. So aggravating factors and alleviating factors is another important thing in tremor study. Okay. So what exacerbates? What alleviates? Alcohol, a small amount, particularly when you advise, tell them small amount. Otherwise, they will go and drink. So a doctor told me to drink and beat the wife and all those consequences. That's just to remember. So Parkinson's tremor, what can reduce the tremors? Prasanna?
It is predominantly a resting tremor, usually asymmetrical.
What relieves the tremor?
Levodopa.
No, not medicine. Some maneuver. Clinically, we are looking at the clinical. Parkinson's tremor, if you ask them to, it's resting tremor, you know. So you ask them to do something, the tremor will go for a while. Suppose the hand is resting, you ask, you take this object. While they are doing it, the tremor will stop, and then after some time the tremor will come back. That is called re-emergent tremor. Okay, just some of the words you are not familiar, you can write it. Re-emerging. Clinically also, when you examine resting tremor, you ask the patient to do something, the tremor goes off. That is usually in Parkinsonism. Okay, and the re-emerging tremor pattern is that after some time, again the patient's the tremor will come back, okay, called re-emergent tremor. There is one other rare condition called isolated resting tremor, where you can put it a resting tremor, commonly Parkinsonism. One other differential is called isolated resting tremor. If you can write capital letters SWEDD, that means actually SWEDD, SWEDD, which actually means that if there are special studies with assessing the dopamine deficiency through a scan, if you do that study, there will not be any evidence of that's called the DAT scan, D capital A small capital T, assessing the dopamine through a scan, D capital A small T capital scan. That will show in Parkinson's disease, it will show deficiency of dopamine. In isolated rest tremor without Parkinsonism, this test will show no deficiency of dopamine. Because we don't do it, we don't think about it. Now, among the action tremors, what will be the most common action tremor, Sai? Most common action tremor. All of
Simple kinetic tremors.
Actually, physiological tremor. Enhanced physiological tremor. That is, suppose a patient is anxious when they come to the hospital, and especially in younger people, you find one of the common action tremors is actually enhanced physiological tremor, that is anxiety, excitement. Then we already mentioned the drugs as a cause. Okay. Now, essential tremor, what is I was asking, what are the differences? I'll tell you the differences from the Parkinson's tremor. One, we said bilaterality. No? Second is, in the essential tremor is relieved by alcohol. We mentioned that, already. Any other difference? Do you know? Family history.
Family history.
Yes. Family history. Can you say it again, Anish?
Site of lesion. Site of lesion.
I didn't.
Means, essential tremor will be this lesion beyond the intermediate nucleus, ventro-intermediate nucleus of thalamus, and
no, we are talking about
clinical.
Clinical, no? More clinical we are talking about. Clinically, how will you differentiate? One is history, I was asking. History, how will it help between Parkinsonism and essential tremor? Family history. Which will have more common, more incidents of family incidents, family history.
Essential tremors.
Essential. 2/3 of the patients will have family history. Whereas Parkinsonism, family history will be only 15%. Okay? So, essential tremor, as I mentioned already, the tremor in the leg is unusual in essential tremor. That's another difference between essential tremor and Parkinson. Parkinsonism can have tremor in the upper limb. If you watch carefully, many of them will have tremor in the legs, whereas leg tremor is unusual in essential tremor. The tremor of the head is more common in essential tremor. Do you know what is called yes, yes tremor and no, no tremor? No? Yes, yes is nodding like this, you know? Yes, yes. No, no means, so the tremor can be like this or like this. So when you watch, observe the patient next time. Today I'm giving you more the history, the clinical points, okay? So you look how is it a nodding type? Yes and no, yes, no. Or that is no. Yes and no. Yes means nodding, side to side. Which type of? That's more common in essential tremor. We have already mentioned different types of tremor. Primary writing tremor, orthostatic, cerebellar we already know about. What is rubral tremor? Looking at various types of tremor names to, yes, who will like to say, Anish? Yes. Rubral tremor.
Relation at the level of red nucleus.
Yeah, actually the name itself gives you but clinically it is a the main thing is the low frequency of the tremor. The 3 to 5 hertz frequency only it comes. 4 to 8 is Parkinsonism, and the other fine tremors are much more frequent. What is a neuropathic tremor? That is a tremor found in peripheral neuropathy. What peripheral neuropathy commonly can present with tremor? CIDP. That much is enough for you to remember. Neuropathic tremor. There is one more tremor, which functional tremor. Can you tell, Sai, do you know about functional tremor? It is actually a psychological cause, not an organic cause. That's why it's called functional. These are the things you have to think of when you see a patient with tremor. Anish, how will you make out a tremor is functional? There are a few characteristics about it. One is the pattern, frequently changing pattern. Look at the pill rolling movements of Parkinson. It doesn't change, you know. The intention tremor doesn't change. The titubation doesn't change. Either the yes type or the no type. Whereas functional tremor varies in frequency, amplitude, the variability. Second is when you divert the attention of the patient, the tremor becomes less or absent. Okay? Inconsistent. And also the disability is out of proportion to the findings. The patient says, because of the tremor, I am not able to cook anything in the kitchen. When you examine, there is only mild to moderate tremor. You wonder, is it really preventing you from doing things? The point is, the disability is out of proportion to the amount of tremor. Okay, those are the few things to remember in different types of tremor. So what we were trying to do today is to look at the tremor a little more in the broader, what is the classification? What are the types? Anatomical, that is the focal, segmental, hemi-tremor, generalized tremor. All these different types of. Okay, how will you treat the essential tremor, Prasanna?
Propranolol can be tried.
Yes. Propranolol can be used, and also in enhanced physiological tremor due to anxiety, propranolol is a useful thing. And as I said, orthostatic tremor, clonazepam is always gait of the patient is to be an important thing to examine in tremor. Okay, the type of walking, that is an important thing to study in tremor. In the essential tremor, what is the classification? Have you essential tremor? That is the benign essential tremor. What we have to see is that is there anything extra other than tremor? The typical essential tremor will have only the tremor, and nothing else will be there. That is the main thing in that. There will be other clinical signs you have to look for. Do you have any questions on tremor as such? Today it's an overview of the tremor, the classification, and different types of tremor. Do you have any questions while you are working here? Do you have any questions? You had some difficulty about tremor as we are closing now. Any issues you have come across in? Yes,
Earlier we were talking about given the middle, sir, actually to bring out maneuvers to bring out tremors. We were telling give a mental task like. Then we have to
more
stop there,
simple
sir.
will be easier for our patients will be move the opposite side, ask the patient to move the opposite side. So tell them to flex the arm, that's a much simpler one. Then of course, making them walk, usually it may bring up and the third is a mental task. The mental task for our patients, not that easy. Why did you ask that question?
Actually, we discontinued with that topic, sir. Just to give a mental task like, and then the connection was.
What mental?
Gone,
I
sir.
was mentioning the backward say numbers, days of the week, months of the year, like that, that is tell the days of the week backwards. So you have to say Saturday, Friday, it takes a little more time, But patients who are a little more educated, but I found the movement will be much easier. Say December, November, October, September, that type of mental task. Okay. So the essential, I'll give you while closing, the essential tremor. There is a society, the Movement Disorder Society, International Society, which has got 4 features of diagnosing essential tremor. 1, isolated tremor, bilateral upper limbs. No other finding. Only tremor is the finding. Okay? Isolated. Number 2, at least 3 years duration. So long duration. Associated head and voice tremor common. And as I said, no neurological signs like ataxia, Parkinsonism, dystonia. Things we have to. Ataxia, cerebellar disease, we have to rule out. Parkinsonism, we have to rule out. And dystonia, we have to rule out. In any tremor, if all these are absent and the duration is long, like 3 years is what the society has given. So isolated tremor, 3 years or more duration, associated head and voice tremor, no evidence of Parkinsonism, ataxia, like cerebellar ataxia or dystonia. I think that is here also, like Parkinsonism, when you find an essential tremor plus other findings, you call it ET plus and look for other findings. Okay, so that is another term. If somebody asks you what is essential tremor plus, that means there is with after plus besides the tremor, there may be some dystonic posture, there may be some memory defect. Anything extra is there. That's what you must look for when a patient comes. When you diagnose essential tremor, always every visit you look for an extra finding. Is there rigidity? Is the walk gait different? So then you will not miss the cause of the tremor. Okay, that's actually I found among the material you can read further. Actually, UpToDate gives very well. Do you have access to UpToDate? I had told Abu today to give, and I was just looking at. I found it was quite good actually in terms of how dealing with 2 topics, that is tremor separately and essential tremor separately. Our hospital UpToDate, is it working? Anish?
Now it is not working, sir.
Okay, can you talk to, I was telling you, talk to Vimal. We have contributed, subscribed to the UpToDate. And so that some of the topics when I take is useful. Here actually it is quite good actually. And I was just looking through before the class, what are the differences. And otherwise the usual simple classification, if you are asked, we used to say that it is resting tremor and action tremor, so here the classification is expanded, kinetic, postural, the classifications, so that gives a better, bigger classification as such. The simplest, at least you must remember, resting tremor, action tremor. And the intention tremor comes in the kinetic. Okay? So we will